the topic that we're going to talk about is emerging treatments for lymphoma, and these are exciting. I'm going to focus more on concepts than on data. I will show some data. I think there's only one Kaplan-Meier curve in the whole slide set, and that took a great deal of restraint. All right, so we're going to be talking about the same disease that we spoke about all morning and talk about new approaches to treatment. You've heard about chemotherapeutic approaches and you've heard about transplant approaches. We're going to talk about vaccine approaches. We're going to talk about a new chemotherapy very briefly because Dr. Rommel did the most spectacular job on this new agent, but people are still working to develop chemotherapy. The chemotherapy is a good thing. It has a bad reputation somehow, but I've cured many patients with chemotherapy, and on our list of new therapies, we will include that approach. Immunomodulatory drugs, in particular, we'll talk about Lenalidomide or Revlimid. We're going to talk about B-cell receptor kinase inhibitors, just remember kinase inhibitors, and monoclonal antibody derivatives, okay? So we're one step beyond Rituxan. Now, the reason radioimmunotherapy is not on this list, and the reason that Rituxan is not on this list, and the reason that monoclonal antibodies themselves are not on this list is I don't really consider them to be new therapies anymore, okay? And finally, everybody's anxious to hear about chimeric antigen receptor T cells and how we can target the cellular arm of the immune system to treat cancer. So what you'll notice is that all of these approaches, with the exception of chemotherapy, are immunologic approaches. Okay, so I'm going to take you through a little bit of immunology and hope that you understand how we're using this approach to treat cancers of the immune system. So, okay, this is my vision of a B cell or a B cell lymphoma cell. They share many of the same features. The malignant B cells and normal B cells have much the same surface markers. In fact, we can map the type of B cell lymphoma you have by studying the constellation of proteins that are on the surface. Everybody knows CD20 because it's been targeted by Rituxan. It's been targeted by Zevalin and Bexar. It is a protein that's used to define and identify B cells in the laboratory, and now as a target. CD19 is like CD20. It shows up first during B cell development, persists throughout B cell development, and even in post-germinal center and pre-germinal center cells where CD20 is less strongly expressed, CD19 is there. Okay, it's part of the B cell. It's a part of a B cell receptor signaling complex. We'll talk about that. There are, on the surface, immunoglobulin molecules. So SIGs are surface membrane immunoglobulins, surface antibodies. So these are proteins that are identical to the proteins this B cell will make when it grows up into a plasma cell and makes antibodies and puts the antibodies into the plasma to protect you from infections, et cetera. Many of you know what they are. Bexar and Rituxan are antibodies. Many of us learned about antibodies because of Rituxan. So I assume that everyone has a basic understanding, but I'm happy to go into it in a bit more detail. There are in these antibodies regions that are unique to a B cell population or clone, but not so. Although every B cell has CD19, every B cell has CD20, and every B cell has an antibody on its surface, the antibody has a region that is unique to the B cell and B cell clone. So if we target CD20 or CD19, we're going to kill all B cells, bad and good alike. If we target just a specific region of the immunoglobulin molecule that's unique to the cancer, then we're only going to target the cancer, okay? Inside the cell, there's targets. So these are cell surface targets, exterior of the cell. These are on the membrane. Inside the cell, in the cytoplasm, there are targets that are part of a B cell receptor signaling complex. So you're going to start hearing a lot about a B cell receptor is the surface membrane immunoglobulin attached to intracellular proteins. So the complex, BCR complex, B cell receptor complex, is this immunoglobulin molecule attached to some signaling molecules. And these signaling molecules will, when the B cell receptor is engaged or stimulated, okay, will turn on these kinases. Kinases are enzymes that shift phosphate groups around on proteins, and the activity of proteins is often determined by its phosphorylation state. So putting phosphates on and off of proteins are what these do, and the proteins work in different ways, whether or not they're phosphorylated. You'll hear about the BTK or Bruton tyrosine kinase, the PI3 kinase delta isoform, and I'm not going to say much about the spleen tyrosine kinase. So these are intracytoplasmic targets for drugs. Not surprisingly, the things that target stuff on the outside are big, like antibodies. They don't get into cells. Or cellular therapies, they don't get into cells. The molecules that target these enzymes are small. They go right through the cell membrane into the cytoplasm to hit their targets. Then there's the nucleus. That's where the DNA is. This is the thing that is getting deeply sequenced nowadays and is being used to study where mutations exist, what genes are on and off in cancer patients, and someday will lead to a very personalized approach to cancer treatment. Okay, we will be able to see that a patient with hairy cell leukemia or malignant melanoma has the same genetic change, and we can target that regardless of the disease. This is where medicine is heading. Anyway, in a very non-specific way, but very important way, chemotherapy targets DNA. And this is what Dr. Rummel was talking about today. So what we'll talk about are how we target all these various properties of the B cell. We have, chimeric antigen receptor T cells, which can attack CD19 and ultimately kill cells that bear CD19. Bispecific T cell engaging antibodies called BiTEs that can do the same thing. We talk about therapeutic vaccination, where we take the unique aspects of this surface immunoglobulin, use it to train the immune system to kill cells that bear that marker. We'll talk about the kinase receptor inhibitors and how these drugs work, and Dr. Rummel told you much about that, and we won't say too much, but I'll briefly go through that. So, and these are just some of the targets. I had to limit this to 30 minutes, okay? Oh my God. All right, vaccine therapy, okay? This is the question. Are we there yet? And I'd like to believe almost, okay? So hang in there and get to understand this. So, most of us, when we think of vaccines, the word vaccine and vaccination has very powerful connotations, okay? Probably next to penicillin or antibiotics, when one thinks of the process of vaccination, one thinks of all the good aspects of medicine and how medicine is impacted on the public health. Probably vaccination, has had more to do with increasing the general health of the world than anything else that we've done in medicine. And it's largely through the application of preventive vaccines. Okay, these are vaccines like smallpox vaccine. We've eradicated smallpox, okay, by immunizing people, vaccinating them so that they have antibodies to that virus and won't get smallpox if they can encounter the virus. Similarly, we all get vaccinated against tetanus and diphtheria and measles and mumps and rubella, and all these diseases can be prevented by getting a preventive vaccine. But there's another way to use vaccines, okay? We don't know a priori that you're going to get lymphoma, and if you do, what your antibody on the surface of your lymphoma cells is going to look like. So we can't make a preventive vaccine. But we can do something that Louis Pasteur did in the 1880s. He treated someone with rabies with a rabies vaccine after the child was bitten by the dog early in the course of the illness to generate an immune response and ameliorate the course of the disease. That's called therapeutic vaccination. Everybody knows about preventive vaccination. I want to emphasize and make a distinction between therapeutic vaccination, vaccine for treatment, versus vaccine for disease prevention. When we talk about lymphoma vaccines, we're talking about therapeutic vaccines, okay? Now, everybody knows what these Y-shaped structures are, right? I mean, Rituxan looks like this in your mind's eye, and so does Zevalin and Bexar. They have radioisotopes, but so does every other antibody in your plasma, or antibody molecule, surface membrane immunoglobulin, that part of the B cell receptor complex that's on the surface of your B lymphocytes, okay, has this general structure, okay? These two arms at the end of them have regions that bind to proteins that give the antibody its specificity. So you can have an antibody against smallpox virus because this region has a shape that binds to smallpox virus protein. That's what defines this antibody's function, its specificity. Okay? How the immune system generates this diversity of antibodies is fascinating, but we'd be here all afternoon, and I'd probably put you to sleep if we got onto that topic. So take it that this is different from immunoglobulin, from B cell clone to B cell clone, from your lymphoma cells as compared with your normal B lymphocytes, and this antigen binding region. And this region, we'll talk a little bit about, is called the isotype or heavy chain region. This also confers properties to the antibody. I'll mention this in passing later. They're not specific properties, they're properties of the class. So there's 5 classes, IgG, IgA, IgM, IgD, IgE, and those 5 classes have properties that are unique to the class. What's most important is that the surface immunoglobulins that we want to vaccinate against are generally IgM or IgG, 2 different classes. They both have the same antigen recognition sequence. In fact, IgMs can class switch to IgGs as cells mature and make slightly higher affinity receptors in the lymph node. And still have a lot of similarity, but the class of the antibody changes and its function changes, okay? The memory antibodies are usually IgG. These are what float around for years and years and years, give you immunologic memory, prevent reoccurrence of infectious diseases. IgMs are usually the first things that pop up, and then they get switched over to IgGs for the long term, and that's kind of what happens. Now, I forgot to mention why I showed this slide. This antigen binding region has a bunch of regions within it that can itself be used to immunize the immune system. We call things that you can use to create an immune response against, we call them antigens. Just a word for a protein that will provoke your immune system into making antibodies or a cellular immune response. It's called an antigen, okay? Antigens bind to the antigen binding region. The antigen binding region has structural features. It's a protein. It has a structure that we call idiotypes, or idiotypic regions, collectively called an idiotype, which are sufficiently unique that you could immunize an individual against them. Even though you make this region, your own body, it's kind of different. It's made to bind to foreign proteins. It's kind of very different from everything else in your body. So you can actually use it to provoke an immune response. And that's why this was initially used to make a therapeutic vaccine for lymphoma. Ron Levy was really the pioneer of this approach. This is an example of an idiotype vaccine. It's an idiotype KLH protein vaccine, which is this is the vaccine approach that has been most studied, that has resulted in a number of phase 3 clinical trials that I'll talk about. And that includes the surface membrane antibody, the entire antibody from the tumor cell, if you're using one approach to generate this vaccine. It's called the heterohybridoma approach. That antibody will have these idiotypic regions that can themselves serve as antigens, and it's hooked to a mollusk protein called keolymphid hemocyanin that's very foreign, really aggravates the immune system, gets it worked up, okay, and mixed with a little bit of GM-CSF and all injected together, it can provoke an immune response not only to the KLH, but it spills over to the idiotypic domains that are part of the immune response provoking complex, okay? Now, in the approach that we worked with, this was generated by taking the lymphoma cells from a biopsy, fusing it to a cell line, and collecting antibody from the cell line that matched exactly the antibody that was on the surface of the tumor cells. Two other approaches were to use recombinant DNA technology, where you took the genes that coded for the idiotypic region and you clone them into generic genes for IgG. It so happens that one used an insect cell line approach, another a mammalian cell line approach, but to make a recombinant vaccine. Everything else was the same. The idiotype matched the tumor, but they all had a generic IgG structure, and they all used KLH and GM-CSF. So these were the idiotype vaccines. And there were 3 studies. The BioVest used the heterohybridoma technique. That's where we take the patient's tumor cells, we make a single cell suspension, pushing it through a screen in some tissue culture medium, fusing it to a cell line, and the cell line just produces this antibody that's identical to the lymphoma surface antibody that could be used to make the vaccine I just showed you. In the genotope approach, the DNA was cut out that coded for the idiotypic regions and cloned and expressed in a cell line, so that you were making a vaccine against the idiotype, but everyone got an IgG vaccine. In the case of the heterohybridoma technique, if your cells made IgM, you got an IgM. If it made IgG, you got an IgG. You were excluded if it was IgA or other heavy type from the study. And there's only 1 or 2 patients that we saw that had that. The Favril used an insect cell line and an insect virus, a baculovirus, to clone the DNA into there and make an IgG idiotype. So these three organizations performed phase 3 studies, okay, which are all published, except the genotope it's under review right now, but not yet in print. Basically, all 3 studies used the therapeutic vaccination approach in follicular lymphoma patients that received an induction treatment, some form of treatment prior to vaccination, and then vaccination after treatment. Well, they were different in that the BioVest or the heterohybridoma technique and the genotope technique took patients that had never before been treated, and the Favril trial, the insect cell line trial, picked patients that were untreated or that had prior therapies and had recurrences as eligible for treatment. They used different treatments. The heterohybridoma approach used a very aggressive 4-drug chemotherapy combination, and this is that was aimed at getting patients into complete response, because the objective of this study was to vaccinate only those patients that were in complete response. We believe that they would be the patients that would benefit most from vaccination, those with minimal residual disease, because as I'll mention later, lymphoma itself causes immunosuppression. Lymphoma cells, when they come in contact with other immune system cells, turn them off, okay? These other 2 trials used alternative approaches and didn't necessarily restrict vaccination to people that had complete responses. So patients that had partial or less responses could receive the vaccine. Okay, so I think that's a fundamental difference here, actually. And in fact, they all looked at survival endpoints, disease-free or progression-free or time to disease progression, all more or less mean the same thing. And the only one that showed any statistically significant difference, and these numbers come from our first analysis, it's actually about 0.027, since we got additional data now that we didn't have at the time that we wrote the paper. This showed a benefit, 14-month benefit in disease-free survival for patients that received the vaccine while they were in complete remission following chemotherapy. There was no statistically significant difference in the other 2 trials for vaccinated versus control patients. And I might add that the control arm in all 3 of these studies used an active immunotherapy, GM-CSF plus the keyhole limpet hemocyanin, the mollusk protein that I told you. So it was truly a blinded all 3 of these were blinded studies. This is the only Kaplan-Meier curve that shows at a median follow-up of 56 months, the disease-free survival was 42 months for the vaccinated patients, shown in the red, versus 30 months for the patients that got a control vaccine. And this was statistically significantly different. Vaccination happened in general between 6 and 12 months after chemotherapy. That was a period that was used to allow the immune system to reconstitute, because drugs that kill lymphoma cells kill normal lymphocytes as well. It's a side effect. And also gave us time to make the vaccine. If your disease came back prior to vaccination, you weren't vaccinated, because we believe and still believe, and the evidence supports that lymphoma causes immunosuppression. This technique relies on having a degree of immune competence to generate immune response. Studies in phase 2 of this product showed that, in fact, people make antibodies against idiotype after this vaccine, and patients also make T lymphocytes. We're going to talk about that in a bit, that kill lymphoma cells following this vaccine. So there's scientific evidence that it worked, and this is clinical evidence suggesting a benefit. Now, these surface membrane immunoglobulins, these antibodies on the surface of the cancer cells, told you they could be one of a couple classes. IgM and IgG in our study were about 50-50. About half the patients had IgG isotypes, half had IgM isotypes, and in a retrospective look, this was not prospectively part of the trial, we looked back to see if patients had different outcomes depending on the class of their immunoglobulin. Remember, the other two companies with negative studies turned everybody's antigen into an IgG. We left you with what you had, okay? And in fact, what was found was that the IgM patients were the ones that had all the benefit. There wasn't a statistically significant improvement in progression-free survival for patients that had IgG vaccine. In fact, we did the same analysis. This is all the controls pooled, and it shows the p-value of 0.01 for IgM and 0.3 for IgG, difference. But if we compared patients that were IgM controls that got the control vaccine, that is, their tumors were IgM, with those that were IgM that got IgM vaccine, or IgG vaccinated patients against IgG patients that got controls, the same thing held up. No matter how you looked at it, all the benefit was in the IgM group. And in fact, if we had done the trial only with IgMs, we would have had a p-value that would have been good enough to get a one-study approval for an indication. But this is retrospective, okay? It has to be, these kinds of things have to be done prospectively to get approval, and also to prevent investigator bias. And you look long enough at data, you start to see all kinds of things, okay? In any event, it turns out, the story is interesting. IgGs actually, I told you they're the memory antibody, okay? It's what your body makes second. And it's because they're actually somewhat immunosuppressive. The body's protecting itself from making antibodies against those foreign, semi-foreign idiotypes, because IgG has regions in its heavy chain of the heavy chain portion of the molecule that turns off an immune response. That's why we use IV gamma globulin to treat autoimmune diseases and things like that. It stimulates a suppressive T cell called regulatory T cells. So it may be that by using an IgG, you're kind of shooting yourself in the foot when you're trying to provoke an immune response. Okay? Again, that's hypothetical, but the data are as they are. All right, moving on. Okay, so one way to provoke an immune response is to stimulate it with a foreign fish protein, GM-CSF, and the tumor antigen. Another thing you can do is unleash the immunosuppression that lymphoma causes. Okay, so we and others have data that this drug, lenalidomide, actually reduces immunosuppression. In the laboratory, if you mix this drug with normal lymphocytes from lymphoma patients, they suddenly can form immunosynapses, something they can't do without this treatment. This turns around immunosuppression, and there's a number of mechanisms by which it does that. So we thought that this would make an excellent adjuvant for an immunologic approach. And everyone knows about Rituxan and how wonderful it is, so we thought maybe some patients don't respond to Rituxan because they're immunosuppressed. And if we use this drug first to reverse immunosuppression and retreat them, we'll get a great response. So that was some thinking that went on to lead us to design this trial, where these patients were all resistant to rituximab, defined as failure to respond or progression of their lymphoma within 6 months of receiving Rituxan, okay, or a chemo-Rituxan regimen. So these were people that didn't respond to Rituxan. You couldn't get on this trial unless Rituxan didn't work. And most of these patients had follicular lymphoma. There were a couple mantle cells and others. I'll show you the distribution. We gave 2 months we did a lot of biologic studies. This is how we're learning about how this drug works on the immune system. And actually have, stay tuned, to what's going on. We'll present some data at ASH this year. We have a biomarker for response to this drug from this study. We treated patients with lenalidomide for 2 months, 2 28-day cycles. In medicine, a month is 28 days, okay? There was a subset that got a low-dose dex with or without, but it's not important for the purposes of this presentation. Basically, 2 months of this, and then patients, regardless of whether their tumors were growing or not growing, or responding or not responding, and I'll show you the results, got Rituxan again, okay, during the 3rd month. And then they just stayed on this afterwards, okay? So it's sort of like a priming with lenalidomide. What we saw was some patients, the lenalidomide itself put them into remission. This is 40 patients that were in this study. So there were 14 patients that had responded, either complete or partial. Overall response rate was 35%. After giving the Rituxan, the overall response rate went up to 63%. And this shows you what happened. Patients that were in CR stayed in CR. Patients in partial response went on to CRs. Patients with stable disease, for the most part, patients upgraded their response during the Rituxan. And it was really kind of dramatic and kind of immediate. During the first week, those patients that had palpable lymph nodes, they would shrink after having been on the drug for 2 months. So in those cases, we believe that it really was the interaction of the 2 drugs. And I'll show you more data about that in a minute. This just I was wrong. There was 2 Kaplan-Meier curves. I apologize. I didn't know that this was on the slide. This just shows progression-free survival. So patients that got 1 single 4-week course of Rituxan, who were resistant to Rituxan, on average, that's the median, progression-free survival was 19 months. Okay? And the follow-up was 20 months, greater than the median, so you know it's a true median. Okay? And now, if you have Rituxan and respond and relapse and get retreated, the duration response is about a year. So this is actually even better than that. And this is in Rituxan refractory patients. And survival was very good because patients stayed on therapy that were responding indefinitely. And there's other good treatments, as you'll see, that patients could go on to if they progressed after this treatment. So we've presented this last year at ASH and are getting set to publish it. And then suddenly adrenaline. This May, when John Leonard shows data from CALGB, they did something just like we did. And these guys, they work fast. They're going to bury us, you know? And I knew that they were doing this, but I never thought a cooperative group could pull it off as fast as a single institution. These guys are good. So, anyway, but look what they did. You had to be Rituxan sensitive to get onto their study. These were all relapsed patients, but thank God they designed it differently than us. So even if we don't get this damn paper done before them, we'll still have something to say, okay? And they randomized patients to either lenalidomide alone or Rituxan and lenalidomide, okay? And what they reported was that the median event-free survival for the patients that got the combination was like ours. So now you got 2 people giving about the same results, but ours are in Rituxan-resistant patients, theirs are in Rituxan-sensitive patients. And like our study, the event-free survival was improved when they added Rituxan to lenalidomide, and the response rate went from 51% to 73%. Not much different than our data. So maybe there's some truth here, Anyway, I was happy to see that. Everybody has the structure memorized after Dr. Rummel's unforgettable speech this morning, and it's a remarkable drug, and it is new, okay? We've been using it for several years, and it's changed our upfront approach, despite the lack of a label in this country for first-line therapy, okay? We oncologists frequently do things outside the label, okay? And basically, this shows his data. Excellent overall response rate in a phase 2 trial by Brad Cal, and in upfront setting compared to R-CHOP, R plus Benda gave not only a better response rate, but a better safety profile. You have the much better slides than this from Matthias Rummel. All right, let's move on to some more of the new stuff, okay? And this is what I think is representative of the new stuff. There's a lot of things going on, but particularly exciting are these molecules. These are a little harder to memorize than bendamustine, but these are the B-cell receptor kinase inhibitors. Remember I said the B-cell receptor is the immunoglobulin on the surface and some proteins inside that are hooked to that sort of get turned on by that receptor when it's engaged by antigen. Or, as we learned the day before yesterday, there was a paper in Nature that came out showing that in CLL, the B cell receptor stimulates itself. There's not some antigen there. There's some unique determinants on this immunoglobulin CLL that makes it constitutively on. It's an on switch that's sort of stuck. Anyway, moving on, ibrutinib has a name. It used to be PCI 32765, and then Cal-101, which is now GS-1101. It doesn't matter. They both inhibit some of those signaling proteins. I'll show you in a minute how they work. Okay? Like I said, if you look at things too long, you start to see lots of things, okay? And, you know, you stare at these things and you see lots of spots, colored spots. But anyway, BTK and PI3K delta, okay? These are two molecules downstream of the B cell receptor that get turned on when the receptor's turned on, or, in the case of CLL, when the receptor's turning itself on. Think about that. And actually phosphorylates downstream systems that actually go and turn on families of genes which actually control all of cell metabolism, glycolysis, et cetera, all kinds of things happen to cells when this is engaged and these things get turned on, okay? Now, PI3 kinase is in every single cell of the body, but different isoforms. Delta is only in the hematopoietic cells. So GS-1101 was designed to inhibit this. The BTK is unique to the B cells because, well, actually, it's in other hematopoietic cells too, to some extent. But it got its name from the immunodeficiency state that happens when you don't have this. In any event, or the person that described that, Bruton, there's molecules for these two things, and you would predict that they would work. And you would hope that they don't have a lot of side effects because they're B cell specific. At least that's what I would. In fact,
and they're pills.
And they're pills. Yeah, one you take once a day, the other you take twice a day. So Cal-101 or GS-1101 is a pill you take twice a day, and BTK you take once a day, okay? And it's not per meter squared dosing. It's like Tylenol. One size kind of fits all. They did phase 1 dose response studies and found out within a certain range it made no difference. You saturated all the receptor sites, and it's so easy to do. They took peripheral blood and they looked at the normal cells and they saw how much of the receptors were full, and they came up with the dose. You know, anyway, follicular lymphoma, in this study, you'll see, this was Lugano presentation, and I thank Chris Flowers for the slide. The 16 patients, 38% overall response rate, and 46% was the overall response rate for evaluable patients. This was intent to treat, 38 and 46 rather, yeah. These were all patients with recurrent disease. What's interesting, the other group that was well studied here is CLL, and look at these response rates, even better. CLL is a disease where that receptor is turned on constitutively. You know, it was the most beautiful paper, the 13th in Nature, of 13th of this month. Follicular lymphoma may be turned on by antigens we don't know about, okay? Just speculating here. This drug works best in mantle cell lymphoma, in CLL, and in follicular lymphoma, okay? The side effects are pretty negligible relative to what we do in oncology. This PI3 kinase GS-1101 is very active in the same diseases that I just showed you. This shows some data for indolent lymphomas, 59 patients. These are lymph node measurements in patients that are on the drug, and you can see this is negative part of the scale, positive. Most patients had progressive reduction over in their lymph nodes. Each line is an individual patient that was responded. So, and they're lined up by progressively better response. So some patients had 100%, that's a complete response, okay? Some patients had 50% and better, that's a partial response. And patients had less than 50%, but some shrinkage, that's called stable disease. But stable disease is a benefit. These patients are taking a pill and they're asymptomatic, and it looks like these responses are ongoing. You know, it's very kind of durable if you stay on the pill. We know how antibodies act. I told you about the constant regions that recruit the immune system cells and complement to kill tumor cells. Now I'm going to focus in the remaining minutes on cytotoxic T cells, okay? So like antibodies that are very specific, your immune system has cells that are very specific. They're very specific in their targets, and they can target viral antigens that are expressed on virally infected cells, or they can target organs if I try to do an organ transplantation on you, foreign tissues. They can also target tumors, and are the reasons that some patients have spontaneous remissions. And there's lots of mouse models showing that you can cure cancer by getting these cells, these cytotoxic T cells or CD8 T cells, to turn on against the cancer cell. In the body, it's kind of a complex process, and it's got to be complex, or these cells could go wild and start hurting you, and you get autoimmune diseases. You have to have antigen-presenting cells that present tumor antigens from dead tumor cells. They scavenge them up, and they show them to these naive or resting, CD8 T cells. They show them in a certain way that turns them on. There's co-stimulatory pathways that have to be present, and interestingly, those co-stimulatory pathways are missing in some cancer patients. It's part of the reason an immune response doesn't get generated against cancer. In fact, there's other ways that cancer makes the immune system paralyzed. Another way is it can interact with these T cells and make them unable to form this immunosynapse that leads to death of the cancer cell. In any event, if you present the tumor antigen properly, these CD8 T cells will kill tumor cells really well. And actually, that was what was so attractive with the vaccine, is that it's been demonstrated now in more than one lab and on more than one occasion that you generate idiotype specific cytotoxic T cells with the therapeutic vaccine that we discussed earlier. Okay? Well, what can we do with T cells that get paralyzed by tumor, or in a patient without a lot of T cells because of prior lymphodepleting chemotherapy? We can take what T cells they have in the lab and stick in them a chimeric antigen receptor. What that is, it's a receptor on the surface that looks a little bit like the antibody molecule, but it's the T cell receptor, not the B cell receptor, because it's on T cells. Structurally, there are some similarities, not identical. And you basically get this into the cells by putting a viral vector into them that infects them and makes them put a receptor on the surface. In this case, what was done here is the chimeric receptor was against CD19, that antigen I showed you at the beginning. So you took a patient's T cells, you transfected it with a viral vector that made the cells express a T cell receptor specific for CD19, okay? And this chimeric receptor had some on switches that were hooked on the inside of the cell. So it didn't need the co-stimulation that you needed in the normal situation. I told you in the normal situation, there has to be co-stimulatory things that happen. It's complex. Well, that's because this receptor needs stimulation from alternative pathways. This receptor on the CAR T cell is on. And the cells go crazy when they hit cells that have their antigens on them and proliferate. And actually, this patient had CAR-19 therapy for CLL, and you could see the lymphocytes disappeared as well as the bone marrow became negative. So this is very preliminary stuff, and just a few patients have been treated. But theoretically, you could make chimeric antigen receptor T cells for anything, CD19, CD20, pancreatic cancer antigens, prostate cancer antigens, anything. This is the beginning of cellular immunotherapy. Now, that's expensive, and the labs, you have to use these lentiviral vectors. They're like AIDS type of viruses, and costs a fortune, and it's complex, and there's some cytokine release issues, and there's lots and lots of things to talk about. But what if you could do it in an easy way? Pull something off the shelf for everybody, not have to take their own T cells and infect them and grow them and give them back, but just to take something like Rituxan off the shelf and give it to somebody, but have it work the way that chimeric antigen receptor T cell works. Well, these BiTEs, or bispecific T-engaging antibodies, are antibody derivatives. They're not really antibodies. They're just two antigen binding regions, single chain antigen binding regions bound together, and they took a T cell antibody, anti-CD3, and an anti-CD19 antibody, bound them together to make blinatumomab. which will bring the cytotoxic T cells into your CD19 tumor cells and kill them. Now, this is fascinating because the CD3 antibody that made binds to a region of the T cell receptor complex, an invariant region, and turns it on. So you don't need any co-stimulation from other molecules. It's like the CAR19 cells. It's on. So you can imagine these T cells circulating around. They're bound by this antibody. They're turned on, looking for something that has CD19, and when they bind them, they kill them the way a cytotoxic T cell does. So it's a new approach. This drug is in a pivotal trial for acute lymphoblastic leukemia, the common leukemia in children. And there's been some phase 1 data in lymphoma, B-cell indolent lymphomas and aggressive lymphomas. I think it's a very exciting approach. It's amazing that it works. So we talked about vaccinate, all these immunologic approaches, vaccination, unleashing the immune system by reducing immunosuppression via immunomodulatory drugs. We talked about kinase inhibitors and how they can be used, how you can change monoclonal antibodies around, how you can change T cells around to fight lymphoma. These are all novel approaches. Where they'll end up, is anybody's guess, but I think they're going to be here for development and part of what we do. And I think really each of these represent, a paradigm. And this emerging paradigm, I think, is kind of the end of the beginning of immunology applied to cancer, okay? And we're now going to get into the next phase of just further refining and using these approaches to target the immune system against cancer. There are other things that we're just beginning, but this is immunology, I think, the pathways that are going to be taken in the next few years. Thanks for listening.
It's exciting, isn't it? I know that some of this was complex and difficult to follow, but I think the bottom line is we are getting to the point where we are getting our own immune system to actually kill the cancer cell in your own body. And some of that may be done with pills, not with hours and hours of infusion chemotherapy. So any questions for Dr. Schuster? We're a little over time, but we'll have our panel discussion and end on time. Any specific questions? Yes, please.
I know it's hard to predict, but what's your...
Use the microphone, please. Thank you.
I know it's hard to predict, but what is your best guess before this gets to be something that is approved for use?
We'll have the kinase inhibitors probably on the market in 2014. Okay, we're doing experiments in the lab right now to make sure they don't interfere with chimeric antigen receptor T cells in the lab, because we're already planning to combine those approaches together.
Questions that were sort of put down for this panel discussion. One of them was the importance of obtaining a second opinion for the diagnosis of cancer. I think we have addressed that. Anyone with cancer should get a second opinion from an academic medical center where research is being done in those cancers. And I think it is important that if you have a physician that says, oh, you don't need a second opinion, you need to find a new doctor. Absolutely. The other issue was the role of complementary and integrative medicine. Janine has joined us. Please, if there are questions about that. I think one of the questions I get asked all the time, and I don't expect you to answer, I'm throwing these out right now, is does stress cause cancer? Every time my patients will say, I had such a stressful event and I got cancer. So Janine's going to try to address that. And you touched on it a little bit. Are there certain foods that I should not eat? I am constantly having patients come in with vials and vials of vitamins and supplements from the natural stores. and overdosing actually on some vitamins. I think that's an important thing to address. One of the other questions that, what is myelodysplastic syndrome? We talked a little bit about that. It's a terrible complication of being overtreated and overtreated and overtreated with, I know Dr. Schuster said chemotherapy is good. I agree with him. It does cure patients. There is no question. But I think what we learned from physicians in the past is that they overtreated these patients who really could live a long time without treatment. So it's when do you need that chemotherapy? That's the important aspect. And the last question here is a question on transformation. We did talk a little bit about that, just if you have any more comments on that. And then a clinical trial, is it right for me? A clinical trial is right for any patient at any time. And you see what they can do in Germany. We haven't been able to do it yet in the United States. To accrue thousands of patients to a clinical trial in a matter of a couple of years. All right, that's just some of the things that we should address. Yes?
Yes, I just want to thank everyone for putting this on. It's great as a patient to have this at our disposal. Thank you so much.
Thank you.
I wanted to ask the question of the panel about second-line therapy and radioimmunotherapy. I know that wasn't really talked about much today, and I'd like to find out more about how that works and what the outcome is and what the recurrence is after that second-line treatment. Thank you.
So I guess I'll start. So radioimmunotherapy is one of the therapies that we did not really address much other than it's mentioned in Betsy's talk at lunch. It is an active and very viable therapy for patients with follicular lymphoma. It is probably the most underutilized active therapy for patients with follicular lymphoma. Like what I said for autologous stem cell transplantation, the earlier in the line of therapy that radioimmunotherapy is used for follicular lymphoma, the more effective it is. And actually, Dr. Gregory's work was the one that she's the one that showed that most conclusively in a paper some years ago. It is a therapy that produces responses related to how soon in the line of therapy it's utilized. In the studies that first led to its approval, both for Bcells, for I-131 tostatumumab, or for Zevalin yttrium 90 pertubumab tiaxtan. I guess I did say it twice today. But both of those therapies have response rates that are more similar than they are different, with response rates in the 20 to 30% complete response rate and overall response rates in the 40 to maybe as high as 60%, depending on which studies you look at. There also is a potential role for each of those therapies, maybe, and more conclusively shown for Zevalin as a form of consolidation after upfront therapy. And that's another place where they also are underutilized as a way of trying to keep the follicular lymphoma away for a longer period of time after chemotherapy is given for first-line therapy.
So I have to comment that Rush has probably had as much experience as any other institution in the use of radioimmunotherapy. We've treated over hundreds of patients with radioimmunotherapy since, and involved in the very early clinical trials going back to 1999. It is a treatment that is easy. It's day 1 and day 7, and it's done. There are no side effects while you're getting that treatment. It's an infusion of a drug like rituximab. And then a little bit later, they give a test dose of rituximab attached to a radiation. And so a lot of patients refer to it as liquid radiation. It's given intravenously. That first day of treatment is over in 3 hours. You have someone come and scan you from our nuclear medicine department to make sure that you're not radioactive and that you're safe to go home. It is a very safe drug. Patients used to be scared because we had to Geiger counter them and they were afraid they were going to be radioactive. That's not an issue. The delay in drop in counts is later than chemotherapy. The low point of the counts is 6 weeks after the drug is given, and the recovery of the drug is 13 weeks later. When it's used earlier, I've never had a patient get a low white count that needed any address. I've never had them get a fever, and I've never had them have any bleeding from low blood counts, low platelets. If it the earlier clinical trials, it was used after patients had failed many trials. And even those patients that responded had a complete remission. I have 12 patients now from my original trials back in 1998 that are in remission for 12 or more years with 1 single week of therapy with radioimmunotherapy. It is underutilized because the oncologist doesn't give the medicine. That 1 week of treatment and that money goes to the nuclear medicine doctor. It is much easier for a physician in his office to give rituximab every 3 months for 2 years at a lot more expense than to give 1 week of radioimmunotherapy. And I could go on for hours, but I'm not, because it is an underutilized form of treatment. You have to have less than 25% bone marrow involvement, so you have to have a bone marrow done. You can't have a lot of tumor in the bone marrow, and your white count and your platelets have to be relatively normal. And that's pretty much the indications. And it was approved for relapsed follicular and indolent lymphoma, but more recently it's approved for frontline use after chemotherapy. And so what I am doing now with many patients, we do 12 treatments a year. I do 1 to 2 a month. I do abbreviated chemo. I don't do 6 cycles of chemo. I'll do an ARC chemo, and then I will consolidate with 1 week of radioimmunotherapy. And we have at least a dozen patients right now that have had that right as frontline treatment that have remained in remission for more than 2 years. And that's early because that's when we just started doing it. So it's very underutilized. Any other comments?
May I just add one thing? There's not really a whole lot of very good information about radioimmunotherapy out there, but if you go to my website, which is betsydeparry.com, there's a whole section on there of radioimmunotherapy. I've got links to studies, links to articles. I did an interview with Dr. Kamensky, who, as I mentioned, is co-developer of Bcells, one of the 2 RIT drugs, almost 2 years ago. There's a transcript on there. And he really talks about it at great length. It was an hour interview.
The Zevalin website also has a great deal of information. One of my patients has done a whole story on the Zevalin website. So the information is out there. You just need to know where to find it.
It is underutilized, and it is also very spectacular. We have a clinical trial that we started in 2006 for patients who've had autologous stem cell transplants that had residual or recurrent disease after transplant. It was a dose escalation study, so the patients that we have the longest follow-up on got tiny doses of radioimmunotherapy. And I have to tell you that we have patients in their 5th year who had disease that resisted high-dose chemotherapy that are in remission after low-dose radioimmunotherapy with Bcells. It's capable of inducing very prolonged remissions. I dare not say cure. We're not allowed to do that. But if you look at patients that are in remission, or those that have complete responses, and they're still in a complete response at 1 year, the probability of remaining free of disease for more than 5 years approaches 50%. Yeah, if you're in remission at a year.
Unbelievable.
It is truly amazing.
And actually, we will have 3 trials for radioimmunotherapy. We're using Zevalin right now, which is the ibertumumab tioxetane. It's a little bit easier to give than Bcells. And it is now that company that is actually sponsoring these 3 clinical trials. One of them is our chemo up front for advanced follicular state, patients who need treatment, frontline treatment for follicular. And the choice of the R chemo is either R-CVP, R-CHOP, or R-bendamustine Rituxan. So again, you've learned that not one of those chemoimmunotherapies is better than another. I mean, maybe one has less side effects, et cetera. And then after they respond to the R chemo regimen, they will be randomized to radioimmunotherapy consolidation for 1 week of treatment or 2 years of Rituxan maintenance. Because that's the big argument out there. Can you do 1 week of consolidation with radioimmunotherapy after you've had R chemo, or do you have to do the 2 years of Rituxan maintenance, which was discussed in the PRIMA trial? So you have to compare the two, and that's being done. The other trial that's being done is in diffuse large B-cell, and we know that's a curable cancer, cured by R-CHOP. But we know that there are sub-patients who aren't cured with it. So another trial that they're looking at is R-CHOP with Zevalin consolidation if the patient gets a good remission versus R-CHOP alone, which is the standard of care. So there are many clinical trials out there. We happen to have several of them here at Rush, and there are many going on throughout the country. And that trial, the two trials I just mentioned are global. They're anywhere in the world. So they'll be opening soon. Yes?
I just had a question. How soon after chemo can you get the radioimmunotherapy?
6 to 8 weeks. You have to recover your counts.
Okay.
We have a couple questions, one from the UK, one from Colorado, one from California, all about RIT. And they want to know when is the best time, or what setting is the best setting for RIT, the most effective, and whether receiving prior rituximab treatment actually adversely impacts the effect.
Would our panel like to address that?
I mean,
earlier is better.
Earlier is better for everything, okay? Every treatment we have, when applied earlier on in the course of the disease, the success rate and the duration of response is better. So, like everything else, that applies to radioimmunotherapy. Patients that are Rituxan resistant or refractory, like that fail to respond to Rituxan or progress shortly after receiving Rituxan, have a lower response rate than patients who are not Rituxan refractory. So giving Rituxan does not necessarily generate Rituxan refractoriness. So to answer your question, does giving Rituxan to somebody make radioimmunotherapy less effective? The answer is not if they're Rituxan sensitive. It seems not really to matter much. In fact, for Zevalin, you give a dose of Rituxan before you get the radiation on the same day. So, and it seems not to interfere. But if you are Rituxan resistant, you can expect lower response rates.
The last question about RIT was, there was some data out of Switzerland last year, was presented last year, about that the benefit of RIT to chemo-resistant or chemo-refractory patients was greater than to others. Can you say something about that?
I'm not sure I know that study. Dr. Kaminsky's original trial, which was 60 patients, a multi-institutional trial, looked at patients who were very heavily treated and they were chemo refractory. And their response to the last chemo was something like 38% with only 3% complete remissions. He used radioimmunotherapy with Bexar in those patients and had an overall response of 60% and 25% complete remission. So it works in patients who failed chemotherapy and rituximab, and patients it did not even, they didn't even have a good response to their last chemotherapy. So it works in chemotherapy refractory patients. You just have to make sure that the patient selection is good.
And it still works in Rituxan refractory patients too, just not as well. In fact, the label, since we tend to be hung up on labels today, is for patients
Rituxan refractory.
Right. It's included in the label. And we all know what labels mean.
Another question was?
We have another question.
Okay.
This one from Australia. These are from all the Facebook groups. They're chatting and giving us questions. This was actually a question for you, Dr. Schuster. And it has to do with the CAR-T19 trials. And they want to know, what has progressed since that article in the New England Journal of Medicine last year, where it was just small.
Yeah, well, 3 patients were reported, and there's been about another 4 treated since that article. So the trials are ongoing, and we expect in the next year or so to sort of have a much more revved up support system for the clinical research and get the trials moving a little more quickly. It's slow going, but when you're doing really early phase work like this, you have to go slow. So as we're learning about the toxicities and some unique findings related to this therapeutic approach, you have to go very slow at the beginning.
But the trials are now opening to other forms of other subtypes of
right now, we've only treated CLL. Okay, the plans are that there will be a mantle cell and follicular lymphoma trial. We initially were thinking it would have been this summer past, but as I said, things are unfolding a little more slowly than we had originally planned. But there's still the next trials that are planned because they target the same antigen, CD19, which is present in CLL. It's present also in mantle cell and follicular lymphomas.
Since these patients have had additional time, since the article was published last year, how are the T cells still as persistent, and how does that affect their overall immune status?
The data that I can tell you is that at last look, the last look I'm aware of, there's evidence that there's persistence of the T cell clones. Also, there's hypogammaglobulinemia, meaning your normal antibody levels drop down because your normal B cells are taken out because they have CD19 on them too. So you need gamma globulin replacement in that situation, which is not that big a deal. I mean, it's something we do all the time in patients with lymphomas that are immunosuppressed for other reasons.
Thank you. Janine, would you answer the questions that we posed at the beginning about nutrition, vitamins, supplements, the other question of stress causing cancer?
Well, certainly, from the literature, there is a tremendous amount of literature looking at the role of stress and how it affects our HPA axis, the kind of the stress response, the sympathetic nervous system, which is our stress response, versus the parasympathetic, which is our relaxation response. And certainly, Janice Keikolt-Glaser out of Ohio State, she did kind of some of the preeminent research looking at the role of stress and immune functioning, where individuals that were under long-standing chronic stressors, actually, they find that their immune systems are compromised. Now, the definitive research on does stress cause cancer is not there in humans. They look at the role of stress, and certainly it can compromise our immune system. And when individuals are certainly facing a disease like cancer and undergoing treatments that also then add to compromising stress and compromising their immune system, anything that we can do to support their immune system by having people feel like they have more control, taking an active role in their health, and certainly how people cope. I think that's the other thing we have to look at. People cope in a variety of ways, and so the research has been done on looking at not only our physiological response to stress, but also then how do we respond, how do we cope with that. And so I think it's very difficult to find any definitive that stress causes cancer. So I don't think that the data is there that would support that in particular. Certainly stress does play a role in our overall health, because typically when we're stressed, we may cope by not eating very well, not sleeping very well, not taking care of ourselves by being physically active, all of those things which we know support our health in general. So that's a kind of Reader's Digest version of the stress literature. There are books written about this. In fact, Carolyn Aldwin wrote a book that was published in 2007 about stress, coping, and development of kind of health-related issues. And she literally reviewed all of the literature that was out there. And so there is no definitive research that says stress causes cancer, but it certainly may play a role in kind of compromising our ability to fight off those types of things. The role of nutrition, I think there is more and more being learned in nutrition. There's more and more research being conducted. There's actually an entire field out there of nutrigenomics that is you're going to hear more about it, I think, as we go forward. And it looks at the genetics of the food we eat and our own personal genetics and how those two go together in the development of health and diseases. And I think we're going to hear more and more. There's a gentleman at the NCI that's doing a lot of research in nutrigenomics and looking at how the role of genetics of the food we eat versus our own genetics and how they go together to keep us either healthy or kind of make us more susceptible to particular diseases.
Right.
And I do think that you had commented about the vitamins and the supplements, and I think people have to be very careful, especially with some of the things that you find at the health food stores, because one has to keep in mind that many of those substances aren't regulated. Andrew Weil and, oh my gosh, I'm blanking on his name. He's a medical oncologist out at the Osher Center in San Francisco. They wrote a book and published a book on all the research in integrative oncology, including what does the literature say, what does the research say on taking these types of supplements or herbal medicine and how it may interact with if you're undergoing chemotherapy. And some of that can actually make you more susceptible to damaging effects. So you just have to be very careful with some of this because it's not regulated. Some of the Western herbs are not regulated by the FDA, and so you never know what you're getting.
Right, and please tell your doctor. Sometimes we forget to, we'll say, are you on any medication? Our patients will say no. We know that over-the-counter medicine, sometimes they're not considered medications. You need to share with your physician everything you're doing. He's not going, if he's a good physician, he's not going to poo-poo it and make fun of you, but he will tell you that perhaps all of our healthy cells need vitamins to grow. Cancer cells probably need vitamins to grow too. So if you're on vitamins and we're giving you something like methotrexate, it may be counteracting the chemotherapy. I just tell all of my patients to stop any supplements when I'm treating them, and I think that's probably a wise thing to do.
I think that there was some literature, I think it was out of Memorial Sloan Kettering, looking at, certainly people are interested in high dose antioxidants, and I think when we are healthy, certainly antioxidants, we hear a lot about them, the foods, all the foods that have antioxidants and anything that we can do, but certainly when you are undergoing treatments, the reality is radiation or chemotherapy is looking to oxidize or kill off those cancer cells, and then if you take high doses of antioxidants, the reality is you may be battling yourself and you may be actually doing yourself a disservice. So I do think it is very important to talk with your physician about anything that you are doing, and certainly talk about what things can be effectively used, what things may be best to put aside until you are in a state of full remission and there's no evidence of cancer there.
Part of the way that reason chemotherapy works is that normal cells can withstand the damage and recover, and the malignant cells can't recover as easily. So what we're saying is, if you're giving, a super protective, dose of antioxidants, you're going to help the cancer cells, which, with respect to the chemotherapy, are more crippled than the normal cells. So, don't do chemistry experiments. Let your doctor know what you're taking.
We're almost to the end. I'm going to ask each of our panelists just to make one comment to the audience today, and anything they'd like to say to the audience. Janine?
Well, certainly as a health psychologist, and wanting to keep people healthy in the midst of a medical illness, I think one thing that I see, and one thing that I found, that the role of, having people take an active role in their health in any way, being an active advocate for their health, anything that we can do to help people get a sense that they are, again, I think like Betsy said at lunch, taking an active role in your life, and kind of our perceptions and our beliefs about, who we are, the world, the environment that we're in. How do we help ourselves to kind of take some control there? That can do a lot to help us be less distressed in a very stressful time.
Betsy?
I would simply reiterate what I said at lunch, but particularly for all of you who may be new to this journey, there is so much hope out there, and it's not just grounded anymore in just blind hope we make it. We have so much good science now that backs up that hope. And as I said to you, in the last 10 years, I have seen more advances. They are truly remarkable, and you've heard some of them today. Cure really is only a word. We really don't need it. We can live with this disease. We can put it in the past. So I would say to all of you, again, take charge of your life. Yes, some of us, or most of us, are at one point or another are going to have to go through some kind of a treatment, maybe 2, maybe 3. But you know what? There really is, just like I said at lunch, so much life with and beyond lymphoma. Live it.
Henry?
Good news is we have a lot of different treatment available for lymphoma, in particular for follicular lymphoma. Bad news is hopefully we don't make you more confused after today's talks. There's so many different treatment options. There's no one straightforward one, A and then B and then C. So it's very important with increasing treatment available that you have a team of doctors that are experts in the area that work with you, partnering with you and your family. Cancer not only impacts the patient, it impacts your entire family. And you need to partner with your doctor to find the best treatment for yourself. Everyone is unique and different, and we are towards I still like the word cure. We're working towards the cure of follicular lymphoma.
Thank you. Chris.
Great. I'll just make one quick comment related to the last point about foods and other issues. We just recently worked on a paper with the International Lymphoma Epidemiology Society, or InterLymph, trying to discover or to look at what is known about the causes for follicular lymphoma. And we have a paper that should be coming out any day now that addresses all of those things that are known. To me, that paper is important for two reasons. One, in that we're trying to discover the things that lead to follicular lymphoma, but more importantly, the first author of that paper is a medical student that worked with me, Alex Ambinder. And his father, Rich Ambinder, is a very famous lymphoma doctor at Johns Hopkins. So we are now moving on to the second generation of lymphoma doctors and lymphoma researchers who are dedicated to trying to develop new strategies for uncovering why these diseases occur and strategies for developing cures for these diseases. And I think one of your roles and the role that you've heard about throughout the day is to learn more about the disease, learn more about all the potential treatment options, but to participate in clinical research and clinical trials where you can help to try and uncover new ways for curing this disease.
Thank you.
And I'd just like to add that the pace of research, and I've seen it in my own career, is staggering right now. And I can assure you that with respect to your lymphoma, the longer you survive, the greater the probability that you'll continue to survive.
Thank you. Again, thank you to our organizers, Liz McMillan. Thank you, Scott, and your wife, and to our wonderful audio-visual staff. Thank you very much, and especially our panel. Thank you.